Boudreau. Our guest today is Dr. Kevin Swan. He's an ophthalmologist with BOHN and Joseph Eye Center here in Lafayette. And he is a cornea specialist, so we're going to talk to Dr. Swan today about diseases of the cornea and what can be done to kind of help our vision. Thank you so much for coming.
Oh, thanks for having me.
It is delightful. I guess before we get started on the cornea and your specialty in ophthalmology, tell us a little bit about you. You're a local boy, grown up and come home,
yes,
huh?
I am from Lafayette originally. I graduated from St. Thomas More. I went to undergrad at LSU in Baton Rouge, and I went to med school at LSU in Shreveport, and I did my internship there in internal medicine. Then I went to Winston-Salem, North Carolina, where I did my residency at Wake Forest University in ophthalmology, and then I did a fellowship in cornea and external diseases and refractive surgery there also, and then I came back home in July of 2010, and it's nice to be back. Thank you.
Did you always know you were coming home, Kevin?
My mom didn't think I was going to come home when I went to North Carolina.
Yeah, because it's pretty up there.
But I had a feeling that my family's from here and my wife's family's from here. So, and there's no place like home.
There isn't.
And Louisiana's great, and we like being in South Louisiana.
And you know, I say it often, but I'm just always so glad when people go away and get their education and their training and then come back and share their skills with us here, because we need it.
Yeah, and it's great to be here.
And why ophthalmology? I mean, you started off, in internal medicine?
Yeah, well, I did. We all do a year of internal, or a year. Your first year, I was called an intern year. So for me,
it's an intern.
Right. So as an intern, but I did it in internal medicine. Okay. But I didn't know I wanted to do ophthalmology until my third year of med school. I knew I always wanted to be a doctor. It was just kind of ingrained in me, I guess. My grandfather is a pathologist. My dad's a general practitioner and does occupational medicine. So I guess it was always in me that I wanted to be a doctor, although he tried to politely discourage me, but always encouraged me to do what I wanted to do. So I appreciate that they gave me the opportunity to do that. But I didn't know I wanted to do ophthalmology until my third year of med school, when I finally did my rotation in it. I didn't know much about it because we don't have much schooling on ophthalmology.
Yeah, it's not like a real high profile, sexy kind of career.
No, well,
choice,
not until you know about it, and that's the key. And so I did my rotation in it, and I saw what a difference in people's lives it can make. I mean, it's great to treat hypertension, diabetes. You're doing a great thing for the patient, but they don't always necessarily appreciate that. But when someone has a problem with their eye, they're not seeing well, has developed cataracts and can't do the things they used to do, like drive, or having difficulty seeing their loved ones or seeing at church, and you can help them see better, you can really make a big difference in their lives, and that's what I really enjoyed. And we also get to use a lot of cool tools. We get to use a microscope every day. We get to use lasers. We get to use ultrasound. We get to use a lot of technology, which makes it a lot of fun.
So you like the technology piece of it too?
It's great. So we get the best of both worlds.
And you know, you're right, and I think it's something that all of us are aware of, that until we have vision problems, or you know, really not just needing glasses, but are at risk of losing our vision, we don't realize how valuable it is. But it's key to our quality of life, isn't it?
Yes, it makes a big difference, especially as we get more birthday candles on the birthday cake.
Yeah,
I find after a certain number of candles, you can't adapt as well when you lose a sense, especially the sight. Kids are very plastic. They can learn very quickly how to adapt. But as you get older, you're used to driving. You're used to going to the store on your own. You're used to seeing. You're used to seeing everything.
And it's how we function.
And so when you lose one of those things, it makes it very difficult to adapt, especially someone with more birthday candles.
Right. Exactly. And I guess that's where the risk gets greater too as we grow, because I guess some of the problems that we have with our vision are just simply a function of age, maybe?
Yes. For example, cataracts. You keep living, you'll develop a cataract, which is a clot of your natural lens. And so it's not the end of the world, because some people, I have the cataracts. I'm like, no, it's you have a cataract, and it's something we can do something about. It's not. It's just a part of getting birthday candles on the birthday cake. It's an aging process.
Are most of the problems that we're going to have with our cornea these days fixable?
A lot of them are fixable, and some in the 2011 going on 2012, we just don't have the technology to fix. But we're learning new things. The newest thing coming about is that we're learning how to grow cells, how we can try and grow someone's own cornea from their own cells. Wow. So one day, hopefully, when we do transplants, we're going to send you to a lab and draw your own blood instead of depending on someone to donate their own cornea. So that will hopefully provide us healthier corneas, and that the body's less likely to reject. So those are kind of things on the horizon. And they're also developing new techniques on how to remove the cornea, how to remove different pieces of the cornea. So just kind of disease specific. So it's nice as things get more specific, we're learning more technology. But unfortunately, as you get more technology, things get more expensive as we're learning and having those issues with medicine. But I hope it doesn't hold us back from developing all those things, and I don't think
it won't. It won't, because you know what? We are curious by nature,
yes.
and it's the curiosity that drives us, I think.
And we also want to help, and so if
Yeah.
there's a way to help someone, I think they will always develop things, and that's the great thing about medicine. It keeps evolving, and that's the great thing about ophthalmology. It keeps evolving, and we keep getting better and better at what we do.
Now, the eye is an incredibly complex organ, isn't it? I mean,
Yes.
there's nothing simple here.
We'll try and make it as simple as possible, but yes. You can. Some people try and compare it to a camera, but what we have is a model here, and we can go over the model of the eye. So here is the cornea, which is the clear shield on the front part of the eye. Behind the cornea is the iris, that's the colored part of the eye. In the center here is the pupil, which is literally just a space, and that's sometimes hard for people to understand that that's just a space.
It seems like there should be something in it.
Right, it's like, what's that dark spot?
Yeah.
And it's a space with nothing there, and it's a space that light travels through. Behind the iris and the pupil sits the natural lens. So when people get cataracts, they get a clouding of their natural lens.
So that's why the light doesn't get through as well.
Right, because if you think when you were born, the lens is nice and clear, but with time it gets kind of gets dingy or yellow and yellow, and at some point there's a tipping point where light just can't focus sharply to the back of the eye. Now, there goes our cornea. Back here is the retina, which is kind of like the film in the camera. That's what light is.
So the retina's going to be where now?
The retina is here, and this is the optic nerve. Now, in the eye, the cornea has about 70% of the focusing power, and the lens has about 30%. So the cornea and the lens focus light to the back of the eye, the retina, and that image is taken to the brain via the optic nerve. So that's kind of as simple as possible.
Huh? Yeah. Okay, so then as a cornea specialist, you're working with the upfront part of all
Correct.
This.
So what we're mainly dealing with is the clear shield or clear window on the front part of the eye. And remember, that has a significant part of the focusing power of the eye. And there are many different diseases that can affect the cornea.
I was going to ask, so what can go wrong with the cornea?
There's a lot that can go wrong with the cornea. Something we take for granted, or a lot of people take for granted every day. People that wear contact lenses, they put a contact lens on the eye, and that's putting a foreign body on the eye. So I will see people with infections. These infections can leave scars behind, and you imagine this shield needs to be clear for you to see your best. If the scar's out towards the side, it doesn't affect your vision as much. However, if the scar's right in the center, it can affect the vision greatly. So we worry about infections, corneal ulcers. So we also worry about, and those can be bacteria. Sometimes they can be a virus. Sometimes they can be a fungus. The virus that causes cold sores can sometimes go to the eye.
Ouch.
And that can, and it can be very painful. It can also cause devastating vision loss, especially if it happens right in the center.
Would that be like a permanent vision loss?
And it can be for some people.
When you say devastating, that sounds like
that's what I mean. Yes, and what I mean by permanent vision loss, a scar that doesn't go away and prevents the person from seeing their best. The whole rest of the eye may be doing fine, but if the cornea is damaged and light can't get to the back of the eye, the patient doesn't see well. And that may be an indication, or would be an indication, to a corneal transplant.
I was going to say, can you do a transplant?
Yeah, so you can do a transplant to fix that patient. Other things that could happen, there are 5 layers to the cornea. The outermost layer is the epithelium. So when people get an abrasion, that's what rubs off. And then that's when they get that painful eye if they were poked in the eye. That's when they get an abrasion when the epithelium goes away.
Is that real serious?
It can be serious, but for most people, they heal up just fine. Usually it's the pain that's the worst thing, but they usually heal up just fine.
Such as eye drops?
Yeah, usually you want to put a patient on an antibiotic to make sure they don't get an infection. And then also you want to try and help them out by putting on, sometimes we have little drops of kind of like ibuprofen for the eye to help protect for pain. Or some people put on ointments. There are different ways to treat it.
Just like an aside, but like let's say somebody gets, an abrasion or a scratch or something. What would be the initial first aid things that they or people around them could do until they can get to you?
Right. So it depends on if they were mud or a chemical or something like that. They want to first rinse out the eye to the best of their ability, and then try and report to the emergency department or call their eye doctor. A lot of times those things seem to happen at night or on the weekend when an eye doctor or a doctor is hard to access.
You get time off too,
But usually it's do your best to rinse it out if something has gotten in it. Some people then call your healthcare provider and try and get in. What we can do is we can numb the eye to make it more comfortable so we can examine. And what we try and do is see the extent of the damage. And usually it's pretty minor that will heal up without any problems. But usually put you on an antibiotic and an eye drop to help with the
But
pain.
immediately just clean it out and call for help.
Right, exactly, because you're not, some people would try and suck it up, but it hurts too much to do that. So usually most people would be calling to try and help out. And within a couple days, the cornea heals really fast. It does much better.
Okay.
Our patients go pretty much back to normal. So we talked about things that can scar the cornea that may require what's called, there are different kinds of transplants. Would be a whole corneal transplant where we remove all the layers of the cornea and replace it with a donor cornea. Where we do that, we usually do it under general anesthesia. Sometimes I can do it where we get the patient very sedated and I put a numbing shot behind the eye, but usually I try and do it when the patient is asleep. We're very fortunate in America. We're a culture that like to give, and not even while we're alive, but we also give after we die. And we're very fortunate. We have more corneas than we know what to do with.
That's a blessing, actually, isn't it?
Yeah, and I think that's just a testament to how Americans are, because there are some cultures, because I spoke with some doctors in third world countries like in Africa, and they can't get donor corneas. They get the corneas that are basically too old to be transplanted in the United States or countries that give. And the reason is because their culture, they need to be buried with all their body parts, and so they don't give corneas.
And maybe their hereafter is a
right,
little
and
different than ours.
exactly. So that's their beliefs, and they just don't. So there's not transplants for them to go around, but there's a lot of people that they could help. So we're very fortunate. We're also fortunate that the cornea naturally doesn't have blood vessels. So the waiting list for transplants, although there's one, it's replaced basically every day. So we don't have a lot of issues getting corneas.
What role does blood vessels have on the transplant availability?
So like for example, if you're going to do a heart transplant or a kidney transplant or lung transplant, there are so many blood vessels going there to feed that tissue. However, the cornea, for it to stay clear for the optics of it, it naturally doesn't have any blood vessels. So its oxygen is fed through the tear film and then also through the fluid on the inside of the eye. And so we just don't need, blood vessels in the cornea are a bad thing because it clouds the cornea.
You can't see through them.
So that's how the body has adapted to have a clear cornea. So what makes that nice is those blood vessels bring the cells that help the body fight infection, help fight foreign bodies, and putting a cornea in there, somebody else's, is a foreign body, and so the body will recognize, hey, this isn't my tissue, I want to attack it and kill it. Well, when you have a heart, all the blood flows through the heart, so there's going to be those white blood cells going through there. However, the cornea, it naturally doesn't have those things.
So it's an easier transplant.
It's an easier transplant because we have access to it, and it's also easier to take care of because you don't have to be on systemic or pills by mouth immunosuppressants where you're seeing a hematologist all the time to make sure that your blood levels are okay.
Right.
We can mainly just treat you with topical eye drops such as prednisolone acetate, which is a steroid eye drop. We usually start about 4 times a day and eventually go down to 1 time a day, and some people don't even need to be on that their whole life. So that's the great thing.
Amazing.
And it's hard to believe that the first transplant was done over 100 years ago on the cornea.
So we figured this out a long time ago.
They figured out how to fix it, but we're not perfect at it, and that's why growing these cells is helping out. So we're hoping to try and, because if you grow your own cornea, the odds of you rejecting your own body go down because it's your own tissue.
Exactly.
And then we also don't depend on an eye bank per se for all this tissue to be done. So hopefully it cut down on cost in the medical.
Is it expensive to do to get a transplant?
Yeah, I don't know what it costs for the eye bank, but there's a lot involved because someone has to harvest the cornea. Someone has to process it, so there's all those fees that go along, and then it has to be shipped, and so all the care process of it. So there's thousands of dollars involved in it. So it's not just let me go pick one up, and then we're going to go right. It would be nice if it was easy, but unfortunately it's not, and everything in medicine seems to be marked up. Well, so that adds the cost to itself.
Or back to research and development.
Yes,
right?
and so, but we can also, some diseases affect the back layer of the cornea, the endothelial layer. And the importance of the endothelial layer, it has special pumps in it.
Is that the last?
This is the innermost layer
here, yes.
So
that's the 5th layer, right?
It's the 5th layer, correct. And this endothelial layer has special pumps in it to help pump fluid out of the cornea to keep it clear. The cornea natural has about 78% or so fluid to it, but it needs to stay right at the right amount. If it has too much in it, it starts to cloud up, and once again, going back to a clouded cornea, you just don't see well with it. When we're born, we're only born with so many endothelial cells, and we all lose them with time.
We don't replace those?
We don't. I wish we did, because it would cut down on some things that happen to the cornea, but we don't.
Okay.
And so over time, we all lose them. Now, most people have enough to where they can go their whole life without having any issues with these pumps. However, some people lose them faster. There's something called Fuchs endothelial dystrophy. This was named after a physician by the name of Ernst Fuchs, and he discovered these endothelial cells. He has his name on a lot of diseases, but this is his disease that is usually passed down from one of the parents. It's called autosomal dominant. So if one of your parents have it, there's about a 50% chance it could be passed down. Okay. And what happens, these patients lose their endothelial cells faster than a normal patient. So they're maybe in their 40s, 50s, or 60s where they've lost so many of these cells that they're starting to develop swelling in the cornea. Well, the treatment for it used to be you could put saltwater eye drops on it to help pull the fluid off of it. It's called Miro eye drops. However, some people, that's not enough for it. And you can get so much swelling in there that not only is the cornea cloudy, you can get blisters on it, and these blisters can pop and become very painful. So not only can it be visually debilitate, it can also cause a lot of pain. So there are different ways to treat it. Initially,
how common is that?
It depends on what your practice is. I don't know what the occurrence is throughout the United States, but it's relatively uncommon. But for me, it's more common because I get funneled these patients.
So it's common enough that it's a significant part of your practice.
Yes.
Got it.
And so what we can do for that is that they said, well, if it's just the back layer that isn't working, why can't we just replace the back layer? And so in 2004 is when they developed a technique called, sorry, it's a long word, but it's Decimate Stripping Automated Endothelial Keratoplasty.
Yeah, it's kind of like if you can say it, you can do it kind of thing.
But it's DSEC, or I just call it a partial corneal transplant, because we're replacing just part of the cornea. And what we do for that is, once again, it's under anesthesia. Usually I'll do the numbing shot behind the eye. And then what we do is...
we're going to try to get a shot of this cornea so that we can see what you're doing.
Right. So what we do is I'm going to remove our natural lens. We don't necessarily do that during the surgery, but what we do is we have a little device that helps remove the back layer of the cornea there. Then what we have, instead of replacing all 5 layers of the cornea like we talked about, we're just going to replace the back layers of it.
That sounds like very delicate work. Huh?
It is very delicate work, and so we devices have been devised to help out and deal with this very delicate and fine tissue. Traditionally, it's done with forceps, where we kind of fold it up, grab it with forceps, and kind of slam it into the eye. But we thought that was very destructive, but that was the best way we had to get it in.
Nor is slam.
Yeah, so, I mean, that's basically what it was. You made an incision, about a 5mm incision, and then you took these forceps and you just pushed it into the eye, and then you kind of unfolded it.
Fluffed it out.
However, my mentor, who trained me, he developed this device. It was initially called the EndoSaver, but they had issues with the FDA in its naming, because they said you had to prove it saved cells. So to save time and expedite it being approved, it's now called the EndoSerter. So it still looks like this here. However, it's just called the EndoSerter instead of EndoSaver. So if you can see here, there's a special little spatula which we load the back layer of the cornea onto. And then what we do is we have this little wheel here that we roll. You can see the arrow, so we'll roll it this way. And what it does it kind of folds that paddle up, and it rolls the tissue into this tube here. And that tube, it goes into this tube, and then what we do is we turn it over this way. And what we do, there's this little device that keeps it from coming out. We take off the black part, and what we do is we insert it into the eye, and we have fluid running through here to keep shape to the eye. And we have this little wheel that rolls it out, and what happens is it kind of unfolds like a parachute, if you will. Now we got to get it to stick. So before we use stitches, so we don't use stitches this way. So what we do is we use an air bubble. So we put an air bubble into the eye, so the patient is looking up at the sky this way, so we're operating this way into it. Okay. So we put an air bubble in there, and so what we do is, if this is the donor cornea, or the natural cornea here, we have the donor cornea here, and then we have that large air bubble sandwiching it all together. So we leave that large air bubble in there for about 10 to 15 minutes, and that helps hold it all together. After 10 or 15 minutes, we let some of the air out. And so the patient's eye becomes kind of like a carpenter's level after that. That air bubble will naturally dissolve with time, so we don't need to go let it out. But what we want to do is try and do our best to keep that air bubble in the right position. So this is usually the hardest part coming up for the patient, which is we ask them to lie flat on their back with their chin and their forehead parallel with the ceiling to try and keep that air bubble in the center. And that's usually for 24 hours. So, so we tape their head down, lying flat, for about an hour after the surgery. Then we let them go home. And then at home, we ask them to do their best to lie with their chin, their forehead parallel with the ceiling, because what I tell them, if the air bubble's right in the center, you're looking straight up at the ceiling. However, if you pick your head up too far, the air bubble will be at the top and only be pushing on the top part of the graph. Or if your chin's too far up, it'll be at the bottom part of the graph.
And if that happens, then the graph won't sit right?
Sometimes the graph, there's about a 5% chance that the graph may dislocate. We'd have to go in and put another air bubble down the line. Now, it doesn't mean that the transplant won't work. It just unfortunately means we have to do another procedure and start from scratch and do the 24 hours on the back.
Okay.
There's about a 5% chance or so the graft may not work, meaning that we thought the tissue was good tissue, we put in there and it just doesn't function. And once again, that goes back to growing your own cells. If we can grow your own cells, then we know we're having good, healthy tissue. Also, like we talked about, there's about a 5% chance it may not stick, and there's a 5% chance or so that the body may recognize the graft and reject it.
And what do you do if that happens?
Usually, if we could just use steroid eye drops frequently, that will help out and prevent the rejection.
Okay, because if it rejects one, would it reject all?
Yes, you're right. The more the first time rejection happens, that you're a little bit more prone to it. But usually we're very fortunate we can just treat it with steroid eye drops, and that's enough for you. Every now and then we have to do other techniques. But these grafts can also be replaced. Some of the transplants have lasted over 50 years. Now this technique, this partial corneal transplant technique, we've only been doing it for about 7 now, so we don't know how long they will last, but we're hoping they'll last the 50 years again, or at least long enough to get the patient through their life.
Yeah, that's really all we need.
And that's the most important thing.
That's really all we need. So I guess are those the most frequent experiences that you have with the cornea, is doing these various kinds of transplants?
Various transplants and different diseases. There's another disease called keratoconus that's relatively common. Keratoconus is referring to a coned-shaped cornea. So our natural cornea is kind of dome-shaped. Like this. But somebody with keratoconus, their cornea is weak, and what happens is that it cones out or pooches out, and so it causes a lot of, I would call it, astigmatism.
Okay.
And the type of astigmatism they have is usually an irregular astigmatism, and it's very hard to take care of. When it's mild, you can just wear glasses or contact lenses, but it comes to a point where that's not enough. So you may have to wear a hard contact lens. They develop devices where you can insert into the inside of the cornea itself. They're called intacts, or little corneal inlays, to help kind of flatten out the cornea. So if you think you're in a dome, you can think of it as being in a dome tent and then sticking out your arms, it would flatten the dome out. So what that does is it helps a little bit with the vision, but also it helps put the contact lens on there. Also, there's something new that's out, and it became big because one of the surgeons that did it on a U.S. bobsledder who eventually won a gold medal. I think it was at the Vancouver Olympics. He's a surgeon in Beverly Hills, and what he did was something called collagen cross-linking. And so what we use is riboflavin and UV light to help strengthen the cornea. So this is experimental still, but a lot of people that's helping that have progressive keratoconus. And at the end stage of it, it will require a corneal transplant if it becomes too steep or scarred. But once again, we're still advancing technology.
So it's really a very exciting field, isn't it?
It is exciting because it's always improving. For me, it's exciting. Like you said, some people don't think it's a very sexy field, but once you get into it, where the ophthalmologists or most of us are excited about things. And then, like my dad told me, I was like, Kevin, no one knows what a corneal transplant or what a cornea person does until they have a corneal issue.
That's right. And when you have one, then you become the most important guy on the block.
Right. And so that once again, that makes it very rewarding that we can help most patients out.
We only have a couple minutes left, and so, but I want to touch base very quickly on cataracts. We talked about them earlier, and so like in a minute kind of thing. For cataracts now, the procedure is pretty safe and pretty simple.
Yeah, we're very, it's the most commonly performed outpatient procedure. We can normally do it with very minimal sedation, and we can use just some topical numbing eye drops for most patients. We have you once again lying on your back looking up at the ceiling, and what we can do is make a very small incision in the clear front part of your eye, the cornea. These incisions vary in size between 2.2 millimeters in size.
You do tiny work, huh?
Yes, we do tiny work with a microscope. It's very delicate work. It can be as small, and some are even smaller than that, but usually somewhere between 2.2 millimeters to 3 millimeters, so very small, and it's usually a self-sealing incision. They were using marketing tactics in the past. Oh, I use sutureless cataract surgery. Most people use sutureless cataract. That's kind of the standard of care now. So if you hear that, it's a marketing tool. Most of us use sutureless cataract surgery. In fact, the vast majority, and pretty much everyone in the United States, is using the sutureless technique. So it's a marketing ploy. But you don't hear that as much anymore.
But we have run out of time,
Okay.
but I do want to say to people,
Okay.
do not be afraid to have your cataract surgery or to find out more about what you need to do, but
Right.
take care of your eyes, huh?
Yes, wear safety glasses. That's a big thing when you're out doing yard work. But yes, but also don't let if your eyes are hurting you, don't sit on them, because that's when a lot of times when bad things happen, when they have let them go too long.
Okay, so call Kevin or one of his counterparts here in Lafayette. Thank you so much for being here today. Wonderful presentation.
All right,
I
thank you.
appreciate it. Thank you. I'm Linda Boudreau. You've been watching The Extra Mile. Thank you for joining us.